Xanax, a presentation by Melanie Nisenson. The generic name for Xanax is alprazolam, and this is a benzodiazepine. Xanax has the typical benzodiazepine structure with an attached triazyl ring. This is similar to a tricyclic antidepressant, which accounts for some of the antidepressant properties of Xanax. Xanax is taken orally as a compressed tablet or as an extended-release capsule. Xanax binds at the GABA-A receptor, which is the most prolific inhibitory receptor in the brain. Xanax binds at the benzodiazepine site, which is between the alpha and gamma subunit, and it acts as a positive allosteric modulator. When it binds, it increases the influx of chloride into the postsynaptic membrane, which hyperpolarizes the postsynaptic neuron. Xanax is a high-affinity, high-potency, full agonist with an intermediate onset of action. Xanax has a shorter half-life and quicker elimination than many other benzodiazepines, which accounts for its increased addiction potential when compared to many other drugs in its class. Xanax also has been demonstrated to increase dopamine concentrations in the striatum, contributing to its rewarding properties. In 1956, Dr. Leo Sternbach created the first benzodiazepine, but these drugs were not marketed until 1963 by Hoffmann-La Roche. In the 1980s, general concern first arose about the addictive potential of these drugs, which led to the largest ever class action lawsuit in the United Kingdom against the drug manufacturers for knowingly selling addictive drugs to doctors without disclosing their addictive potential. 1 year later, in 1981, Pfizer first marketed Xanax in the US, and sales quickly started to rise. It wasn't until the 2000s, though, that studies started to question the use of benzodiazepines such as Xanax in a clinical setting because of their risk. Despite this research, in 2012, over 49 million prescriptions were written for Xanax, making it the second most prescribed psychoactive drug after hydrocodone. Xanax is prescribed for anxiety disorders such as general anxiety disorder and social anxiety disorder, although it is not the first line of treatment for severe to moderate anxiety, in which selective serotonin reuptake inhibitors are the first line of defense. Xanax is also used in the treatment of panic disorder with or without agoraphobia, panic attacks, nausea due to chemotherapy, and insomnia. A standard therapeutic dose of Xanax is between 1/4 to 1 milligram. However, people who take it recreationally usually take between 2 to 4 milligrams. Some acute effects of Xanax are drowsiness, disinhibition, respiratory depression, constipation, anterograde amnesia, difficulty concentrating, dizziness and lightheadedness, as well as impaired coordination. Some chronic effects of Xanax include irritability and mood swings, depression, insomnia, hypotension and tachycardia, liver disease, acute kidney damage, edema, shortness of breath, and muscle cramps and twitching. When we're talking about long-term use of Xanax, we're really talking about 4 milligrams a day for 3 months, or any daily dose that starts to have negative consequences associated with dependence. And this can have both permanent and reversible damage. Some examples of permanent damage are cardiovascular, kidney, and neurological damage, whereas ear, nose, and oral damage can be reversible. You might wonder, is Xanax addiction common? And in fact, Xanax is a pretty addictive drug, even at low doses. Doctors used to think that dependence only developed at high doses, but recently, animal and human studies have shown that dependence is highly possible even at low doses. Currently, Xanax is the most prescribed and misused benzodiazepine in America, and an estimated 30 to 45% of chronic benzodiazepine users are dependent. Thus, doctors have recommended that benzodiazepines like Xanax are only prescribed for a maximum of 7 to 14 days to avoid becoming dependent, even on only a medical prescription, not abusing them. Tolerance is one of the driving factors of Xanax dependence. Tolerance to the anticonvulsant, hypnotic, muscle relaxant properties of Xanax can develop within days or weeks, as well as rapidly to the sleep-inducing effects of Xanax. Furthermore, after 4 months, there is little evidence that benzodiazepines such as Xanax retain their anxiolytic properties at all. However, this is somewhat contested in the literature. The mechanism of tolerance for Xanax is internalization and desensitization of the GABA-A receptors, which we know is downregulation, particularly at the substantia nigra. There's also upregulation and sensitization of the AMPA and NMDA receptors, as well as changes in expression of neuropeptides such as corticotropin-releasing hormones and neuropeptide Y. In one study, researchers investigated the cellular changes associated with tolerance. They injected benzodiazepines into control and tolerant users. In the control users, there was an increase in growth hormones, whereas in the tolerant users, this effect was blunted. This shows some of the many physical adaptations to Xanax dependence. There is also a characteristic benzodiazepine withdrawal syndrome caused by several underlying factors. One of these factors is an increased sensitivity to excitatory stimuli, and this excess glutamatergic activity results in excitotoxicity, which can lead to neurodegeneration in the long term. There is also a rebound effect of the HPA axis and long-term changes in the function of the GABAergic neuronal system, which accounts for many of the typical benzodiazepine withdrawal symptoms. These symptoms include high anxiety, irritability, cognitive difficulties, seizures, tremors, sweating, sleep disturbances, and many other symptoms that are virtually the mirror images of the drug effects. Xanax withdrawal symptoms usually begin within hours after reducing the dosage and peak within 2 weeks. If left untreated, these symptoms can continue for months in what is called a protracted withdrawal state. Abuse of Xanax has risen exponentially in the last decade. It is a Schedule IV drug by the DEA because it does have medicinal properties. In 2011, a study found equal distribution among different racial groups and between genders when surveying nightclub users of Xanax. In 2013, the National Survey on Drug Abuse and Health found that young adults ages 18 to 25 were twice as likely to abuse Xanax as young adults ages 26 and over. According to the Treatment Episode Dataset Report of 2011, over 60,000 people in abuse programs are addicted to Xanax, which is a threefold increase from 1998, when that number was just over 22,000. This coincides with an exponential increase in emergency room visits due to Xanax. And of these emergency room visits, over 50% involved another substance. Some of these substances are alcohol, opiates, and other drugs that we have talked about in this class. Combining Xanax with other substances is very dangerous, especially when the other substance is a central nervous system depressant like alcohol. Alcohol and Xanax interact synergistically to cause impaired memory, decreased breathing and heart rate, and severe sedation, which could lead to possible coma and death. Furthermore, these substances both rely on the same enzyme, cytochrome P450, for clearance from the liver. Thus, they have to compete for the active site of this enzyme, which increases the amount of time these substances spend in the bloodstream, and thus increasing the chance of overdose. However, there are a variety of treatments for Xanax addiction. Gradual tapering of Xanax is the standard of care, since stopping abruptly can result in seizures and death. Adding a longer-acting benzodiazepine to this tapering has been effective in decreasing cravings and withdrawal symptoms. Also, cognitive behavioral therapy is a helpful treatment, and it has been proven to help with relapse prevention and stress management, which we know is a common trigger for relapse. Flumanazole is used in more serious cases. It is a competitive inhibitor of Xanax and has been shown to alleviate withdrawal symptoms. However, it can only be used in a hospital setting because it has been shown to cause seizures in many cases. Finally, combining any of these therapies has been proven to be more successful than using any one strategy alone. In conclusion, I'd like to acknowledge these studies, articles, and websites for the content, images, and statistics I have provided. Thank you very much.